Among those lipid biomarkers, the most important is LDL cholesterol. Bad cholesterol, high levels can predispose to the development of plaque in the arteries by depositing cholesterol in the wall of the arteries. HDL cholesterol can take cholesterol out of tissues rather than bringing it into the artery. It can help remove the cholesterol, and that has been associated with reduced heart disease risk when levels are elevated. The situation with HDL cholesterol has become much more complicated in recent years for the following reason: that raising HDL cholesterol therapeutically, which can be done either with lifestyle measures such as weight loss and exercise or certain drugs, that increase in HDL has not been found to be beneficial in terms of heart disease risk. So the worst combination for heart disease risk among those three is having high LDL, high triglyceride, and low HDL. The LDL cholesterol is really an imperfect measure of what's really going on in the circulation. Levels of smaller LDL particles in the blood are much more strongly associated with heart disease risk than the larger LDL particles.
Hey there, welcome to the Happy Habit Podcast. I'm Matthew. You'll find me here every week talking health and well-being. If you're getting any education or any value from these episodes at all, you can show your support. It is free. You can like, subscribe, and share with other people. Tell others who you think might also get some value and enjoy these episodes too. Plus, if you're on YouTube, become a subscriber over there. We are speeding our way towards 3,000 YouTube subscribers. So if you've not already subscribed on that platform, well then please do so. You can also like and comment on any of the episodes. Now, heart health and cholesterol in particular has caused much confusion in recent years. Today, I hope to dispel some of that confusion as I speak with Dr. Ronald Krauss. He is a medical research professor and an advocate of a low-carbohydrate diet. We hear why LDL cholesterol is not a perfect measure of cardiovascular ill health. Why? Well, because LDL particles come in different sizes with varying protein content and pose different risks. HDL has traditionally been deemed to be the good cholesterol, but raising its levels hasn't been shown to be beneficial in terms of heart disease risk. In fact, HDL that is too high is now viewed as a risk factor for heart disease, and we discuss why. We also learn about ApoB and Lipoprotein A and why they are important biomarkers, especially in families with a history of heart disease. I find out how arterial plaques form and if it's possible to clean out our arteries and how long that process takes. And we talk about the importance of limiting carbohydrate intake if we want to address our heart health. Any discussion about cardiovascular health will include the term cholesterol and the trifecta of HDL, LDL and triglycerides. Can we start by talking about that all-important trifecta of biomarkers? Why are they so significant when it comes to cardiovascular health? And maybe we can dive into how our understanding of those biomarkers has changed since your early days when you started in Berkeley.
Among those lipid biomarkers, the most important is LDL cholesterol. That's low-density lipoprotein cholesterol, or the bad cholesterol, that is very strongly associated with heart disease risk. It's been known for decades now to be a risk factor. People have high levels either due to genetics or to dietary practices. Those high levels can predispose to the development of plaque in the arteries by depositing cholesterol in the wall of the arteries and building up material that can sometimes block the artery and cause heart attack and stroke. So that's really the most significant of those standard risk factors. The second part of that triad is HDL cholesterol, high-density lipoprotein cholesterol. And that's cholesterol contained in lipoproteins, which are actually particles that can move in the other direction, that can take cholesterol out of tissues rather than bringing it into the artery. It can help remove the cholesterol. And that has been associated with reduced heart disease risk when levels are elevated. It can actually be associated with low heart disease risk. However, the situation with HDL cholesterol has become much more complicated in recent years for the following reasons. I'll spend a minute on that because this is a topic that has been really quite confusing to many people, and rightfully so. because while it's true that low HDL cholesterol is associated with higher heart disease risk, it's what we call a biomarker. It has been difficult to prove that raising HDL cholesterol therapeutically, which can be done either with lifestyle measures such as weight loss and exercise or certain drugs, that increase in HDL has not been found to be beneficial in terms of heart disease risk. So while HDL can be a marker for heart disease risk, it has now become less of a therapeutic target because that causal relationship has not been proven. And the second aspect of that, which is actually related to what I just described, is we're now learning that people that have very high levels of HDL on the other end of the spectrum are also at higher heart disease risk. And we're beginning to try to understand that. That's a research area that I and others have been involved with, because HDL can acquire properties that can actually be unhealthy to the artery. So there's a sweet zone in between very low and very high HDL where there is a good relationship with heart disease risk, but it's really become much less important as a clinical tool to try to improve heart disease by changing HDL. The third component in that triad is triglyceride. Now, what we just talked about is cholesterol. Cholesterol in two different forms. One, LDL, again, these are particles that contain cholesterol. The second, HDL, particles containing cholesterol. Triglyceride is a completely different entity. It's a different kind of fat. Cholesterol is a fat, but triglyceride is a more common kind of fat that is found, for example, in fat tissue. That's triglyceride. Or when one has cream or butter, the creamy substance is triglyceride. That is also associated with heart disease risk. Higher levels are associated with increased heart disease risk. So it's another marker that is independent of LDL. It sometimes is associated with low HDL. Triglyceride levels are high, HDL levels are low. And that actually is an axis that may explain part of the risk associated with low HDL. That is, its association with high triglyceride. Because high triglyceride represents a form of fat in the blood that can also lead to buildup of plaque in the arteries for a variety of reasons. These are particles that are formed in the liver that carry triglyceride, and they're also formed in the intestine. When one consumes fat, one can find triglyceride levels going up in the bloodstream, and as they're metabolized over time, they can acquire pathologic properties. So it's the metabolism of triglyceride in the circulation that can add to the heart disease risk. And so the worst combination for heart disease risk among those three is having high LDL, high triglyceride, and low HDL. And that represents a condition which we call atherogenic dyslipidemia. These things tend to come together very often. And particularly the high triglyceride, low HDL axis is a central feature of that. So that atherogenic meaning buildup of plaque in the artery. Dyslipidemia is a term describing this disorder. So that atherogenic dyslipidemia term is a way of embracing that entire interrelated set of risk factors that are unfortunately very common in the population. I'll just mention, since this might come up in some of your questions, this is very strongly associated with increased body weight. People that carry excess fat, particularly around the middle, who are at risk for a number of conditions such as type 2 diabetes and other metabolic traits, are also at risk for having heart disease by virtue of this atherogenic dyslipidemia that is worsened as one develops more and more abdominal fat, and conversely can be reversed if fat loss is achieved.
Just on that, further complicating any discussion about LDL is the fact that there are small particles and larger particles. So not all LDL particles are equal. Is that the case?
That's exactly what I was about to mention, because having described the general characteristics of these measurements, the LDL cholesterol is really an imperfect measure of what's really going on in the circulation. Because as I mentioned, cholesterol is a component of a particle of in this case, an LDL particle, which is a spherical substance. It's like a little micro ball that has fat and protein in it. It's called a lipoprotein because it contains lipids and protein. And it's those particles that carry cholesterol into the artery wall that we're concerned about. And so having now focused on the particle nature rather than just the cholesterol content, we learn a lot more about what's actually going on that could increase heart disease risk. Because as you've mentioned, and this is something I've been deeply involved with myself, these particles come in different sizes. And so LDL is not just a single kind of particle. It's a whole spectrum of particles that can be grouped generally into two categories based on their size, as you mentioned, larger and smaller LDL particles. And there's ways of measuring that in the blood. And one can then zone in on measuring the type of LDL. And as those studies have been done over a couple of decades, it's been demonstrated that levels of smaller LDL particles in the blood are much more strongly associated with heart disease risk than the larger LDL particles, which when one looks at the composition of these particles, one gets a little bit confused because the smaller LDL particles actually have less cholesterol than the larger particles. So one might think, well, maybe that's not so bad. But the problem is those smaller particles have other properties that make them more damaging to the blood vessels. They can get into the wall of the blood vessel more easily than larger LDL. They can get broken down and oxidized, which is a very damaging effect, and they get more sticky. So these particles actually have much more damaging properties, and that's been associated in measuring those small LDL with higher heart disease risk. Now, this kind of closes the loop because those smaller LDL are also associated with higher triglyceride and low HDL. So when I mentioned earlier atherogenic dyslipidemia, high triglyceride, low HDL, and high LDL, it's really the small LDL that really is the important feature of that atherogenic dyslipidemia. Larger LDL can be damaging, but they're more weakly associated with heart disease risk.
People in the audience then will be interested to know if it's possible then to test for those smaller LDL particles if they go to their doctor and ask for these biomarkers to be screened. They'll be familiar with having cholesterol done, HDL, LDL in general, and their triglycerides. But is it possible to have small LDL particles assayed?
There are assays for that. Unfortunately, they're not universally available globally. In the United States, there's a couple of major laboratories that offer testing for these particle subclasses. I will mention that there is a surrogate that is widely available, which is an important test. It's called ApoB, ApoB, and that is a measurement of a protein that is the main protein of LDL particles. As I mentioned, LDL is a lipoprotein, and this is the protein part of that lipoprotein. And there's one molecule of ApoB in each LDL particle. And it turns out that concentrations of ApoB, when they're elevated, very often indicate higher levels of the smaller LDL. So patients that have high levels of small LDL will almost always have high levels of ApoB. And conversely, if one measures ApoB, one can infer a greater likelihood of having these smaller LDL particles in excess. And that test is available in standard labs. So that's an acceptable surrogate. It's not a perfect measurement of small LDL, but it gives at least an indication that could be a fact.
There's another test that I've discovered that comes up in this conversation also, and that's lipoprotein A. Could you talk to us about the significance of this in the discussion?
I'm glad you mentioned that because that is another important player in heart disease risk that has been known for a number of decades, but that has been largely overlooked in the clinical setting, in part because while it's associated with heart disease risk very strongly, as well as stroke, it is tightly regulated genetically. So people that have high levels of LPA tend to have relatives who have high levels of LPA because they carry genes that are strong determinants of these LPA concentrations. Having said that, there's many different genetic variants that contribute to this, and collectively, we find that perhaps a third of the population is carrying genetic variants of LPA that put them at high risk of heart disease. But as I mentioned, this is not and really major target of treatment for two reasons. One is this genetic component, and it's very difficult to overcome. And related to that, the second reason is that until very recently, drug companies have not put any effort into developing treatments that could help lower LPA. That landscape is changing, fortunately, now. People are beginning to recognize that lipoprotein A or LP(a) is important enough to represent major therapeutic target. In the next couple of years, we expect to see reagents available that can help lower LP(a). Right now, it can be measured. There are standard techniques for doing that. Should be available in most clinical laboratories. And I generally recommend when we're screening for heart disease risk, when we're measuring the cholesterol profile, the various lipids that I measured, the ApoB LDL particles. In addition to that, I would include an LP(a) measurement, not necessarily because we would aim to lower the LP(a). That's not going to be feasible in most cases, but because if we identify individuals who have high LP(a) early on, we can mitigate the risk of heart disease by aggressively improving their other risk factors, such as lowering the LDL, and that can override the damaging effects of the high LP(a). So we look for that LP(a) as a means of determining whether we should be aggressively targeting risk in general and LDL lowering in particular. And the other reason we recommend measuring LPA in families, particularly if there's a strong family history of early heart disease, is detecting elevations in family members. So if there's somebody that comes in that's a high LPA, there's a 50% chance that either their offspring or their siblings or parents would be carrying this gene as well. So it's a way of opening the door to discovery of high risk in people that may have perfectly normal health, but are carrying this time bomb in their bloodstream.
What is the relationship between cholesterol, LDL, HDL, lipoprotein A, and the development of atherosclerosis, which is characterized by these plaques in the arteries?
The plaques originate with the deposit of cholesterol in the wall of the artery, and that's because lipoproteins, and particularly LDL, and more particularly small LDL, LP(a), they all carry cholesterol in the blood, and if they bind and get stuck in the artery, that can lead to cholesterol being released into the artery wall. That can set up a buildup of plaque, and it can also form the stage for a very important process, which is inflammation, because the cholesterol and the other features of the lipoproteins that wind up in the arteries can trigger inflammation, that is, buildup of molecules that can cause plaque to become relatively both larger but also unstable. And it can also then start to break down. When the plaque starts to break down, it can lead to the formation of a clot on top of that plaque. So this whole process of atherosclerosis starts with a cholesterol buildup, but it can advance to these more dangerous stages once inflammation has set in, and that's where we have the risk for both heart attack when that happens in the blood vessels of the heart, or stroke if it happens in blood vessels in the brain. That breakdown of the plaque is what is the final step, unfortunately, for many patients who don't survive.
A really important question, is something I hope that you can clarify. No doubt you will. Time and again, I have seen people online, medics and other people who purport to be experts in this area, talk about it being possible to reverse the buildup of plaques in arteries. Is it possible to do so?
Depends on how advanced the plaque is. As I mentioned, there's a stage where the plaque evolves from a simple cholesterol buildup to these more dangerous advanced stages. In the early stages where cholesterol is the main component, it is definitely possible to reverse the plaque. If one lowers the blood cholesterol level, one can achieve a movement of cholesterol out of the plaque into the blood, eventually get broken down and excreted from the body. And so that will shrink the plaque. At later stages, there is more inflammation. There can be thickening, we call it fibrosis. There can be calcium deposits on top of the arteries. That makes them more stiff and more difficult to reverse. But fortunately, the dangerous part of the plaque, even at the advanced stage, is the cholesterol that's contained inside the plaque, which is called soft plaque. So you can have this more advanced hard plaque that is kind of a scar tissue containing soft plaque inside of it that can be removed in the same way I just mentioned. If blood cholesterol levels, or if LDL levels are reduced, the cholesterol can move out of the soft plaque. And so there may still be evidence of the hard plaque, but that hard plaque is not dangerous. That is a relatively safe form for the plaque to be in once the soft plaque has been removed. So that is possible. Having said that, from a therapeutic standpoint, for somebody that may have developed some degree of plaque, and this can be detected in various ways through imaging, it's possible to reverse heart disease risk, but more importantly for most people, the goal is to just stabilize the plaque so it can sort of heal over and be less likely to crack, rupture, and cause clot formation. So that we call stabilization. If the plaques can be stabilized, even if there's some cholesterol in them, they're much less dangerous, and that's a reasonable goal. So we don't necessarily have to reverse the plaque. We're quite happy if we can just stabilize that plaque, and that can be done by various health measures focused around cholesterol improvement.
Well, talk to me about that then, about stabilization or indeed reversal, be it soft or hard plaque. Would you approach that by changing your diet or exercise, medication, or a combination of all three?
Well, the keystone of prevention is diet and lifestyle, because we know that there are dietary practices that, particularly in susceptible individuals, they have genetic traits that render them more likely to have an increase in their LDL levels. We know that saturated fats, particularly in red meats, and to some extent in certain forms of dairy, can raise LDL. But more importantly, in our population, it's a different dietary approach that we need to consider, because we're dealing with individuals who are overweight who need to control their body weight to improve their lipid profile. And that involves the smaller LDL particles, which are increased in patients who have that excess fat. And it's not saturated fat is important here, it's carbohydrates. So it turns out that these days, the kind of problems we're seeing in the population are much more likely to be related to this atherogenic dyslipidemia and this high triglyceride, small HDL, low HDL. And that is benefited by restricting carbohydrates, primarily simple sugars, sugary sodas, or anything that has added sugar is very harmful. Processed carbohydrates in general, white starches that don't contain the whole wheat fraction are also bad. So the overall program is really, for most patients, a focus on limiting those carbohydrates and being careful about their saturated fats, doing whatever they can to keep their body weight low. In those individuals who have genetic traits that render them resistant, who just can't achieve the targets that we see for their lipid profile by diet measures, exercise is another important feature that should be considered. But we often have to move to medications such as statin drugs, which can help to lower those bad LDL.
You mentioned dietary fats there. Can we talk about what you would suggest to be good sources of dietary fat?
It's a concept that is a little bit tricky to define, because we really tend to think about fats as if they're consumed in isolation. That's the case, for example, in salad oils, you have the pure fat. But for the most part, the fat we consume is better to consider in terms of the overall food that contains those fats. And so it is reasonable, based on the evidence, to point to the fats in seed oils and nuts in particular that should be, I think, legitimately called healthy fats, but it's the overall food that they're consumed in. We're less sure that if one consumes those fats in isolation, that they have the same benefits. So we're focusing more and more on getting healthy fats from foods, nuts and seeds, rather than trying to load up on oils, for example. And so that is certainly a healthier choice for most people than foods that are high in animal fat.
this feeds into your contention that the optimum diet really for human beings is one based on whole foods.
Yeah, and feel very strongly about this. I've been involved with nutrition for many years, and nutrition science has a lot of fascinating features. But the more we break foods down into their components, the more we lose in terms of understanding what their health effects might be. And so we get much more information by considering patterns of food intake, and particularly patterns such as what we call the Mediterranean diet, which is heavy on plant sources of protein and fats, moderate in meat consumption, rich in fish, which having a beneficial effect on heart disease. That combination of foods is really a dietary pattern that is much more important to aim for rather than trying to sort of focus in on a particular food or particular component of the food, which is considered in isolation, doesn't really take into account all the complex effects of the various foods that we're consuming. And for example, cheese, which many people consider a bad guy because it's derived from dairy fat, it turns out the fermentation product of milk fat and the way it's cultured can have dramatic effects on health and cholesterol levels in particular. And so most cheeses actually are not harmful because of that fermentation tends to change the effect on blood cholesterol. So that's a really good example of where a food should be considered as a potential goal, consuming that food, rather than trying to consume or avoid a particular component.
And then we mentioned just very briefly earlier, from a behavioral standpoint, the role of exercise and what it can play when it comes to enhancing our cardiovascular health.
Yeah, exercise, of course, has a huge number of benefits across the board health-wise. From the standpoint of cardiovascular health, we can start with its effect on energy balance, that is, burning off that excess fat as a way that can augment dietary efforts to reduce body weight and keep body weight optimal, reduce that fat around the middle in particular. So exercise is a key element of that. It's both endurance exercise as well as weight bearing, weightlifting type of exercise. That mix is proved to be very beneficial. And so part of that benefit is through weight management, but there are also effects on lipid metabolism. It can improve that lipid profile we talked about. The atherogenic dyslipidemia can lower the triglyceride, lower the small LDL particles, lower the ApoB, and so it augments diet as a benefit for heart disease risk.
Is it possible to navigate this space, particularly in your latter years, without having to resort to something like statins, for example? Is it possible just to be able to control your blood cholesterol levels, your LDL, your ApoB, etc., just via diet and exercise alone? Or would one have to ascribe to some kind of medication regime?
Probably the majority of the population can manage their lipid profiles effectively with diet and exercise. So I think that's true for the majority of individuals. But there are many individuals, unfortunately, who carry genetic traits that make them more resistant to the benefits of diet and exercise. Those individuals will continue to have lipid profiles that put them at high disease risk, and they do need to be considered as candidates for statin treatment. Not everybody with those lipid levels, however, is necessarily destined to get heart disease. We have a statistical likelihood that higher levels of LDL, for example, would increase their risk, but we can't guarantee that this is 100% the case for any individual. Some individuals can escape those damaging effects. What we are doing more and more now is evaluating the need for statin, not just by measuring the lipid profile, but if we're uncertain about whether or not they need to be treated with a statin, we'll do a test called the coronary artery calcium scan. That's available, I think, around the world. It's an X-ray procedure that can quantitate the degree of plaque in the artery, measures the amount of calcium in plaque. And if individuals have no evidence of any plaque from that test, we can with more confidence, we can tell them it's not necessary at this point to take statin treatment. They have not developed any plaque. Conversely, individuals who are kind of resisting statins may be convinced to take statins. If we show on that test that there is a buildup of plaque, that sort of turns the arrow in the direction that should be more aggressive in those patients. So it's very much an individual decision. We have general guidelines based on lipid levels, but that we need to individualize those guidelines in many cases using these kinds of tests.
So for somebody who's concerned then about their own cardiovascular health, ideally they need to have the biomarkers that we mentioned already screened, but also the calcium scan done as well, just to be sure.
Yes, a calcium scan is a very good way of confirming the absence of plaque. If that score is zero, it's very, very helpful in terms of being able to advise the patient that diet and exercise may be sufficient, at least for the time being. Periodically, one needs to recheck the scan to make sure that nothing has developed. But as long as it remains negative, that can be very reassuring.
And how quickly can somebody turn around their situation if they have been found to have plaques in their arteries?
Surprisingly short period of time. The blood lipid levels, the cholesterol levels, triglyceride levels can respond within a matter of months, a month or two of changing diet or taking medication if necessary, can significantly lower abnormal levels of these lipoproteins. And then subsequent to that, over the course of perhaps 6 months or a year or less, that change in the lipid profile can be translated into improvement in the health of the arteries. So it can happen fairly rapidly. The buildup of plaque over time is where we get into heart attack risk. And so you can't expect it to be reversed immediately, but it can be reversed relatively quickly.
Well, it's great to know that you can reverse it if you take your health into your hands and you avail of the medical expertise at hand. Really fascinating discussion. Thank you so much. You have obliterated some myths that I was under the false illusion of up until this point. So I do appreciate your expertise in this regard, certainly in relation to reversing the buildup of plaque in the arteries, because I wasn't aware that it was possible until now. But Dr. Krauss, thank you so much for your time today. Really appreciate your answers and your insight. Thank you so much for joining me.
It was a pleasure.
Well, thank you for tuning into this episode of the Happy Habit Podcast. If you enjoyed it or any of the previous episodes, like, subscribe, and share with other people who you think might enjoy them too. Until next time, stay happy.